When a patient abruptly discontinues lipid-lowering therapy, specifically statins, the clinical outcome is dictated less by the gradual return of circulating cholesterol and more by an acute pleiotropic rebound, a sudden loss of the drug's lipid-independent anti-inflammatory stabilizing effects on the vascular wall. While a stable primary prevention patient with clear vessels might simply revert to their baseline lipid curve over a few weeks, an individual with established atherosclerotic disease enters an immediate, highly volatile window of plaque destabilization. When intracellular statin concentrations drop to zero, the sudden unblocking of the mevalonate pathway triggers an overshoot in the production of downstream isoprenoids, that is, lipid intermediates like farnesyl phosphate, that anchor signaling proteins to cell membranes. This sets off a rapid cascade of adverse vascular mechanics. The raw ROCK activation spike. The sudden glut of isoprenoids causes an extreme overactivation of the raw associated protein kinase. This drives acute vascular smooth muscle contraction, spikes local reactive oxygen species, and suppresses endothelial nitric oxide synthase, the enzyme responsible for generating vasodilatory nitric oxide, instantly shifting the endothelium into a vasoconstrictive prothrombotic state. Within days of withdrawal, activated macrophages inside the atheroma ramp up the transcription of matrix metalloproteinases, enzymes that degrade collagen and extracellular matrix. This rapidly thins the protective fibrous cap overlying the lipid core. The sudden loss of statin-mediated tissue factor suppression prompts an uptick in circulating thromboxane A2 production. If the newly thinned fibrous cap suffers even a microscopic fissure, local rheology strongly favors immediate occlusive thrombus propagation. Systemically, the hepatic upregulation, the compensatory increase in cell surface receptor density of LDL receptors, reverses within 14 to 21 days, returning circulating serum ApoB and LDL cholesterol back to their pre-treatment baseline. Because this rebound phenomenon strikes the microenvironment of the vessel wall long before a standard lipid panel reflects the change, the clinical danger of stopping cold turkey scales entirely with the patient's underlying vascular anatomy. For a stable primary prevention patient, immediate hazard within 0 to 30 days is negligible acute risk. Serum lipids normalize within 2 to 4 weeks. Long-term trajectory, gradual return to patient's baseline lifetime atherosclerotic risk curve. For stable chronic coronary artery disease, there is a subclinical spike in vascular inflammation and subtle endothelial dysfunction. Accelerated expansion of existing necrotic cause and a higher 1-year major adverse cardiovascular events risk. But it is quite different in acute coronary syndrome setting. Severe risk of acute cap rupture, target lesion thrombosis, or fatal reinfarction. Long-term, markedly elevated 90-day mortality, historically doubled compared to maintained therapy. The hazard of abrupt statin cessation in an unstable vessel is a classic biological paradox. The drug successfully quieted the inflammatory crosstalk of the atheroma, but withdrawing it acts as a cellular stress test, handing the inflammatory momentum right back to the vulnerable plaque.